as they were saying, I'm Chris Manwart. I specialize in hip and knee replacement, and they asked me to come and speak in how falls relate to hip fracture. The equation is simple. Falls plus osteoporosis equals fracture. And as you can see with this patient, let me back up, the fracture is here along the femoral neck. Can everybody see there is no arrow. Do we happen to have a laser pointer? I have a laser pointer. The fracture is here along the femoral neck. And as logic would have it, if you can boil this down to an equation, you can boil it down to a solution. If you can prevent the osteoporosis and prevent the falls, you can prevent the fracture. So how do you prevent? We'll start with osteoporosis. How do you prevent osteoporosis? You lay bone down. You lay a lot of it down, and you do it when you're young. And for most of us in this room, those days have long passed us by. But for our children and grandchildren, we can still have some impact on their bone quality as they enter their 60s, 70s, 80s, and 90s. A diet rich in calcium and vitamin D. In the American diet, that's milk. If they can't drink milk, they need to get their vitamin D and calcium some other way. And as much as it's important to take it in, it's important not to lose the calcium. The number one thing that leaches calcium from our bones is pop, soda. Help those kids drink milk, not Coke. And of course, avoid alcohol, and nicotine is horrible for bone. We want everybody participating in weight-bearing exercise, and especially your kids and grandkids. We want them doing exercise. Historically, that was farm work. That was sports. But now it's as important not to sit in front of the TV, gaming and using the computer. We need to be active. It's probably one of the few things that Michelle Obama and I agree on, is that we need to be more active and have a better diet. Once we get to midlife and beyond, it's about maintaining our bone. And the way you do that, again, good diet, but remain active. Keep doing that weight-bearing exercise. Go to the gym. Push some iron. Keep that bone density good. Bone responds to stress. Wolff's Law is exactly that. Bone responds to stress. Stress your bone and it'll get harder. Especially for women, hormone replacement in their 40s, 50s, and 60s, if appropriate, it's not always appropriate, but if appropriate, can help maintain bone, especially if they've had an early hysterectomy or early menopause. And beyond that, it's pharmacological treatment. Mr. Adams, can you raise your hand? James Adams runs a osteoporosis clinic for us, and he can evaluate your bone density, and pharmacological treatment if you need it. Thank you, James. The second part of the equation is falls. Preventing falls is critically important. So how do we do that? We maintain a healthy nervous system. Again, that's good nutrition, avoid narcotics, and use alcohol in moderation or not at all. And I'm not going to steal Al's thunder, because Al's going to talk about what the therapist can do for you to help prevent falls. But physical therapy is critically important in combating the effects of aging, disease, stroke, chemotherapy, other things, Parkinson's, other things like that. Physical therapy can have a huge impact. Can everybody in the back hear me okay? Louder? All right, I'll keep talking loud. So when it comes to hip fractures, basically there are four types. There's the pelvis fracture, the femoral neck, the intertrochanteric fracture, and the subtrochanteric fracture. When we talk about pelvic fractures, the pelvis is a ring, and you can't break a lifesaver in just one place. So commonly, if you break your pubic ramus, superior and inferior pubic ramus, you're also going to break your sacroiliac, this part of the tailbone. The nice thing about those fractures is they're stable. They don't need surgery. In about 6 weeks, they'll heal. They are, however, painful. The next type I want to talk about is the femoral neck fracture, as we showed with the first patient. They can be undisplaced, where you can't see it on x-ray, or they can be displaced. they all require surgery. If they're undisplaced, we get an MRI scan. You can see how they light up on MRI scan. There's no doubt that patient has a fracture. That patient will come to the emergency room unable to bear weight. The x-ray won't show the fracture. Everybody kind of puts their hands in the air. That patient needs, if that's you or your spouse or sister or child or parent, they need an MRI scan. And historically, how we fix an undisplaced fracture is we pin it. And modern pins are these cannulated screws. Historically, there's been a number of different kinds of ways to pin a hip. 90% of these will heal and do fine. 10% of them fail for one reason or another and need a hip replacement. This patient, the one I showed that has the undisplaced fracture, they're bone on bone in the hip. And so we went ahead and started with the hip replacement to save her an operation. For the displaced fractures, the ball dies. The ball dies and will collapse down. And so replacing the ball, doing a hemiarthroplasty where we just replace the ball is one option, or again, doing the hip replacement is the other way that we fix these fractures. The next type of fracture I want to talk about is the intertrochanteric fracture, fracture between the greater trochanter and the lesser trochanter. The fracture goes in between there, and again, they can be undisplaced, can't see them on x-ray, and again, the answer is to get the MRI scan. There's no doubt that that's broken. In an undisplaced fracture, usually we'll fix them with a screw and plate apparatus. This is the lower part of the same x-ray here, and the screw slides into the plate, the two connect together, you can compress the fracture, and this is a nice way to get those undisplaced fractures to heal with minimal trauma. Some of these intertroch fractures are completely displaced. You can see the ball here with the upper part of the femur and then the lower part of the femur here. And those are nicely fixed with a screw rod design where you put the rod down the bone, screw through the rod up into the ball. Another example of the same thing, this patient has a three-part, the ball, the shaft, and the lesser trochanter, and these screw rod devices are very nice for fixation of these intertroch fractures. Bottom line, whether you fix them with a screw rod or screw plate construct, they need to be fixed. We keep these patients on a walker for about 6 weeks, and typically they'll heal real well over that 6-week period. The last type is the subtrochanteric fracture. The subtrochanteric area of the bone is here below the lesser trochanter. And those fractures almost always get fixed with a rod screw construct. We allow those patients to bear weight, and they usually heal without a lot of difficulty. So, not to over-dramatize this, but to drive the point home of how important it is to avoid falls and to avoid or treat osteoporosis, 10% of people that fracture their hip break the other one within a year. 30% of those people are dead within 90 days. 50% are dead within a year. It's a big deal. Avoiding fracture is critically important. After a hip fracture, it's very important to be involved. If it's your family member, make sure that somebody is at the hospital with the patient. You need to help facilitate communication. If mom is in the bed, delirious from all the pain medicine, the medical team may see her as a nursing home patient that's got dementia and that this is baseline, not realizing that mom was home taking care of herself last week before she fell and broke her hip. Please communicate that to the medical staff so they know, so everybody kind of is on the same page about the expectations and what the plan is after she gets over this fracture. It also helps to have you there because you can help encourage mom to, and by the way, can I introduce my mom? Wave your hand, Mom. So, thanks, Mom. That's Dad next to her. Thanks for coming out tonight. It's there to help encourage, to be there to help encourage mom to get up and walk, to do the physical therapy, to be up in the chair. Because if she doesn't get up and get going, she's not going to do well. Bed sores, blood clots, pneumonia, and death. Early mobilization is the key. We'll talk more about that. you lose about 10% of your strength per day that you're at bed rest. And so the key is to fix a hip fracture quickly and then get the patient up quickly. Preferably, we like to fix these the same day and have the patient up the same day, if at all possible. Physical therapy daily or twice daily. Up in the chair, once the patient gets to rehab, we'd like them to walk with the family. Nursing and therapy can't be there every moment, but if the family's willing to walk with the patient, get that patient moving, the patient recovers more quickly. Encourage, encourage, encourage. Spinal anesthetic. If you can give these hip fracture patients a spinal anesthetic, it keeps a lot of drug out of their brain and minimizes the risk of nausea, vomiting, and delirium. They have a lot less of the hangover effect. And by the same token, avoid narcotics as much as possible. Tylenol and Celebrex are pretty good pain medicines, and they avoid constipation, delirium, and respiratory depression that you get with the stronger narcotics. The respiratory depression, you're not taking as deep a breaths. That's the setup for pneumonia. So in conclusion, the answer is simple. Prevent the osteoporosis, prevent the falls, and you can prevent the fractures.
You know, like the song says, the knee bone's connected to the hip bone's connected to the spine bone. I'm next up the line here. Mine's going to be a little bit more brief than Dr. Banwart's, but no less important. There are a tremendous amount of aging-related changes that happen to the spine that cause falls and gait trouble together. And this is kind of a classic question when you come to the doctor with back pain, walking issues, leg symptoms, is what we call the shopping cart sign. And it just has to do with gait and walking and how people as they age start to get out of balance. And it's frequently a subconscious thing where you start to lean forward just a little bit, because that leaning forward just to the slightest degree opens up every one of those nerve holes a little bit. And if you stand up nice and straight, it just narrows those nerve holes down enough that people start to get symptoms. And so subconsciously, as we age, we kind of start to throw ourselves out of balance just a little bit. And that is a precursor to just being unsteady and the whole issue of falls. So spinal stenosis is a common cause of gait disturbance as people age. And there's two main types. There's cervical stenosis depicted on the right side here. This is a picture of somebody who's been split in half essentially, and their brain is up top. This is the back of the neck back here, and the spinal cord there. And you can see the spinal cord comes down, and there's several spots where it's pinched. And that's spinal stenosis. And spinal stenosis is essentially any narrowing on the spinal canal from numerous causes. It can be, you can have spinal stenosis from disc herniation, spinal stenosis from bone spurs, spinal stenosis from fractures, spinal stenosis from tumors. Essentially, there's a multiple cause of why people get stenosis, and most people have multiple causes. So they say, well, is it a bone spur that caused it? Yeah, bone spur is one of 5 parts of this that all usually go together in most patients to cause stenosis. When you get stenosis in the neck, it gives you a certain set of symptoms. When you get stenosis down here in your low back, you can get some similar symptoms, but you also get kind of a characteristic set of symptoms in your low back that we'll talk about in a little bit. So almost 500,000 Americans have spinal stenosis symptoms every year. And again, it's due to degenerative changes in the spine where this is a normal picture, and this is somebody if they were cut in half laying on their belly. So you have your disc up front, your spinal sac behind. You have these little, what are called facet joints, or I call them the knuckle joints that go down the back. And then when you push on your back, that's the bone that you feel there. And this is the nerves in the middle. As we age, we start to get a little bit of arthritis of those knuckle joints. This yellow, which is the ligament around those joints, starts to thicken, and that ligament starts to pinch and push in there. This disc starts to, instead of being dented in like it is over here, it starts to bulge out, or it can bulge out a lot. And that combination of all of those factors starts to pinch and and narrow on the space where those nerves are running down. And again, if you lean forward, you get a little bit more room, but eventually get to the point where you can't lean enough to get the pressure off. What people tend to notice when they get pinching, and this is of a low back, what they get is numbness, tingling, and even some muscle changes where they start to get an uncoordinated gait. Again, it's typically due to disc bulges, arthritis of the joints, and thickening of the ligaments, or even some slippage. Sometimes as those knuckle joints wear enough, it's like getting a loose U-joint that starts to shimmy and it starts to slide forward and it lets that spine slip forward. And all of that combination is what causes the narrowing or the stenosis. So common symptoms are sciatica type pain, low back or leg pain, weakness, heaviness. People sometimes say they feel like they have concrete on their low back or their buttocks. If they stand too long, it just starts to feel like a heavy weight. It tends to be worse with standing and walking and better with sitting or leaning over on a counter. There are multiple treatment options for stenosis. We typically start very conservatively with anti-inflammatory medications, therapy, traction, chiropractor, epidural steroids. When you do an epidural steroid, essentially you put a cortisone shot here, or if you specifically have pinching on one side or the other, sometimes we come in at the side. And if you put a little bit of cortisone next to that spot, it will shrink up some of that inflammation and again, give just enough room that those nerves start to breathe and say, ah, and have a little bit of relief. And that's how cortisone injections tend to help. Beyond that, you start talking about surgical treatments for your spinal stenosis. And this is one where we would probably be talking about surgical treatments. This is a side view on an MRI where the spinal sac is coming down and then it's pinched off completely and there's a little bit of slippage forward. Again, it's open in the middle, and then again at the disc level it's pinched off completely, and that one significantly slipped forward, and then the spinal sac. This is a normal look at that. You're looking up at somebody actually, and that's the spinal sac, and the little dots in the white is the spinal fluid. In this, it's just completely gone. That's somebody who we would still consider trying shots and therapy and those kind of things, but that is pinched enough, and if their leg symptoms are enough to justify it, we would typically talk about doing either a laminectomy, where we basically come in and come from the back and unroof the house, or if there's enough slippage, sometimes we have to do a laminectomy and a fusion where we put hardware, rods and screws and spacers to keep that from slipping anymore, because sometimes when we cut out that's pinching right there, that's the last bit that's holding it stable, and so you're forced to put hardware in to stabilize it. In the neck, you get similar symptoms, but in the neck there is a spinal cord that can be pinched and spinal nerves that can be pinched. In the low back, if you're down below lumbar 1, which is kind of the high part of the low back, there's really no spinal cord left. The only thing you're going to get is spinal nerve symptoms, and there's a difference between when the spinal cord gets pinched and the spinal nerves gets pinched. When spinal nerves get pinched, you tend to just get kind of that shooting arm pain, numbness, or weakness in the arm. If your spinal cord gets pinched, you can get that kind of, you get spasticity, your arms kind of can get rigid, you get kind of a drunken gait, you get clumsy, you can't really feel where your legs are. You can actually get bowel and bladder changes. Real difficulty with fine motor movements or rapid motor movements, trying to do your buttons on your shirt, your handwriting, holding that pen and doing fine motor skills tends to be affected in people who have significant pressure on their spinal cord and their neck, and kind of that shuffling gait. And again, this is somebody who has a little bit of disc bulge, but you can see the spinal cord still has plenty of fluid and that spinal cord is a little bit indented. This is somebody who's pinched from front to back and that spinal cord is significantly squashed. Just because the MRI shows compression doesn't necessarily mean we have to do anything. It's one of those very key points that you have to treat the patient and not the MRI scan. They did a study years ago where they took 100 people who had never had neck or back symptoms, ran them through the MRI scan, and roughly equivalent to their age, is the amount of MRI findings that the radiologist described as surgically important. So if you're 80 years old, there's an 80% chance on your MRI scan you're going to find something that says disc herniation, bone spur, something that sounds very, very ominous, but you may have never had a clinical symptom from it. And so the bulging disc is the most overrated structure in the world. I mean, everybody gets excited about their bulging disc, but very, very often that is really not what is clinically important or relevant. And so it's where actually seeing somebody, visiting with them and seeing what their symptoms are and putting these two things together become very important. This person here, if they started having arm pain, weakness, problems with their gait, is somebody that you would talk about surgery with as well. All of these things, we still talk all of our, depending on their symptoms, we'll talk conservative things for neck issues as well. Therapy, traction, just pulling on the neck sometimes will pull that disc in enough that people can get some relief. Again, steroid shots or cortisone injections in the neck can shrink up that inflammation sometimes to give relief. And then eventually, in some people, we have to talk surgery. Surgery in the neck is either from the front, like this person had, where we put little spacers in through the front and a titanium plate, or from the back, if it's significantly pinched over several levels. Sometimes we basically have to unroof the back of we basically take the roof off the spinal canal, and then we put these little screws and rods in from the back to hold everything stable. Both of those things do affect motion. We do have disc replacements these days. It's not typically used for bone spurs and arthritis. It tends to be soft disc herniations, and so for this kind of thing, a lot of patients come in asking about it, and the number of people that would really qualify for a true disc replacement in this setting is pretty low. Kind of along the lines of what Dr. Banwart said, prevention, prevention, prevention. Quote from Floor, if you fall, I'll be there. Don't meet the floor.
Well, I appreciate everyone being here. I see quite a few familiar faces. As Kurt was indicating, my name is Alison West. I'm a physical therapist. Anyway, I appreciate your time. One of the things I wanted to talk about, like what everyone was mentioning, is concerning falls and the fact that we are trying to make an increase in awareness of the issues that happen after the falls. So obviously the docs talk about that, and from the standpoint of the physical therapy, I wanted to discuss what we can do to prevent. I did want to mention a few of the facts. Some of the facts that have, they're found in the research has indicated that there's a high incidence of falls. 1 out of 4 individuals age 65 and older will end up, as Dr. Ibsen said, meeting the floor. Because of the high incidence of falls, there is a high incidence of, obviously, admissions into the hospital, as well as injuries sustained after those falls. All right. The September, in case you guys hadn't seen the little article, September, especially the first day of fall, has been indicated or recognized as the National Falls Prevention Awareness Day. It's a national move that is, at this point in time, driven by the National Council on Aging, as well as 70 additional organizations, including the CDC, as well as the National Institute of Health. So these kind of seminars and educational programs are taking place throughout the United States, once again to make the population aware of what can be done, of what the possible causes are or side effects, as well as just make people understand that you have to take the steps to address the problems before they happen. So I was going to mention a couple of the facts. Like I mentioned earlier, 1 out of 4 Americans 65 and older has a tendency to fall. Every 11 seconds, which to me, these couple of facts were they just really opened my mind or my eyes from the standpoint of an older adult, 65 or over, falls every 11 seconds and ends up in the emergency room. I mean, those are pretty high numbers. Every 19 minutes, somebody aged 65 or over passes away because of those falls. I mean, dramatic numbers. Obviously, it's the leading cause of fatal injury, and it's also classified as the most common fatal and non-fatal type of emergency room visit that requires hospitalizations. 2.8 million falls leading to, 2.8 million individuals end up in the emergency room post falls. Total cost back in 2013 was $34 billion. It's expected to be $54.9 billion by 2020. Some other research articles indicate it could be as high as $60 or $65 billion of healthcare costs involved in treating those falls. So why do we fall, right? Obviously, the most important part of preventing falls is maintaining normal walking. And what exactly is normal walking, right? So normal walking requires unrestricted moving joints. So if somebody has arthritis, they're going to have some additional stiffness. They're not going to move as effectively or as efficiently as they should. So it is really, really important to make sure that you're keeping your joints nice and loose. Walking also requires muscles contracting in the right pattern or sequencing. And then you also require the right amount of muscle strength to hold you up. If the muscles are not contracting in the right pattern, maybe you have a little bit of ataxia or abnormal walking pattern because of a stroke or because of previous injuries or because of a spinal cord injury, then you're losing that ability to effectively contract the muscles to keep you upright. The feedback that the muscles, or the brain, requires to maintain the individual upright is called proprioception. That's just the ability to know what your body is doing in space. So if you close your eyes, you know you're bringing your arm out to the side, and those receptors within the joint are telling your brain what your muscles and joints are doing in space. And that is so important when you're walking, because every time that your foot is hitting the ground, it's receiving feedback from the floor to let you know if you're standing on a carpet or standing on grass or gravel or firm surface, or if you're stepping in a hole, or if you miss a step all the way and your ankle's beginning to turn. That feedback is what tells the brain which muscles to activate to keep you from falling or falling as hard. Also, another aspect of walking is visual input. 10% of the balance information that the brain requires is vision. So as we all age, right, thanks to my glasses, so we start to lose that ability to see distance or maybe that depth perception. So it is very, very important to make sure that we're addressing that as we age as well. If the visual information is not getting to the brain, we're increasing our chances of falling tremendously. The other factor, which is responsible for about 20% of your balance, is accurate vestibular feedback, which is a little gyroscope inside the inner ear. You have a gyroscope on the right and a gyroscope on the left, that every time your head is turning, you're looking up or down, those little receptors are telling the brain the position of your body in space. If those gyroscopes aren't working properly, then your brain may not necessarily perceive movement as effectively as it could. As you're turning your head to the right, the neck muscles are telling the brain that your head is turning to the right, but if the gyroscopes inside the inner ear are not feeding the brain that information, it may get confusing information as to whether or not it is actually moving or not moving. Okay. So why do we fall? Everyone loves cats, right? So why did that cat fall, right? Well, there are many factors. You know, my mom is pretty good about calling me, and she'll give me a problem, and she'll expect a yes or no answer. My coworkers know that I never give a yes or no answer because there is no such thing as a yes or no answer. So somebody will ask me, why do I fall when maybe I turn my head to the right? Why do I fall? Well, there could be multiple factors that led to that fall, right? The research has been conducted, and they came up with about 19 factors that can affect your ability to stand and walk and transfer your weight from left foot to right foot, or affects your ability to turn quickly without losing your balance or stumbling. So obviously, factors that indicate higher risk of falls, of course, previous falls, I'm sorry. Weakness, because if your brakes in the legs, so to speak, the muscles are the brakes. If the brakes are not working properly and you go to stop or to maintain your upright position, if the brakes fail, your bones, your joints are going to collapse. You're going to end up falling. So you do need strength. Of course, we talked about the balance impairments dealing with the inner ear. So you need those gyroscopes to be working as effectively as possible. Multiple medications also affects your ability to maybe maintain your cognition as sharp as possible. We all know that certain medications may make you sleepy. So if you're sleepy, you're more prone to fall. So it is really, really important to make sure that when you are taking certain medications, that you're doing things to prevent or minimize the likelihood of that fall. I mentioned arthritis earlier, you know, the stiffness in the joints, and if the joints are not moving fluidly, that increases your chances of fall because the joints are not able to keep up with the pace of movement. And of course, a few other factors that were mentioned. Let's see, diabetes is actually a fairly common factor. Diabetes not only can it affect your vision, it can affect the nerve ending's ability to transmit that information from the feet up to the brain. So every time that you're stepping, that feedback that the brain is expecting to get is not getting there because the nerve endings have been damaged by the diabetes. So you're losing what's called some of that somatosensory input. Well, that kind of input makes up 70% of your total balance. So I mentioned 10% being vision, 20% being the inner ear, and 70% being that input coming from the legs. So it is really important to make sure that the information is getting to the brain so that next time that you step on a hole or you start to twist your ankle, the brain is able to counteract those abnormal movements and maintain you upright. All right. The research conducted has also indicated that of those 19 risk factors, there are 4, of the 19 risk factors, if an individual has 4 out of those 19, they're at a 78% greater chance of falling, right? The research also indicated that the most important factors to look at, or the most common factors to look at, are the obviously previous falls, which I thought that was kind of odd that, you know, the research says, yeah, you've fallen before, you're gonna be at a greater chance of falling again, which kind of makes sense. Weakness in the legs. So if the brakes are not working properly, the body's going to have difficulty slowing itself down, whether it's going from a standing position to a sitting position, climbing down stairs, walking fast and coming to a stop. If the brakes aren't working properly, you're going to keep on moving. Balance and gait abnormalities, of course, with those little gyroscopes in the inner ear that I was mentioning. Use of psychoactive medications. So medications that affect your alertness and your cognition, of course, will greatly increase the sharpness of the brain to function and to keep you upright. So what can be done, right? So we have to figure out what the problem is. So in the case of the little GIF that I put out, a little video, right? The guy keeps pushing the start button on the treadmill and he keeps on falling. So you need to figure out or have somebody help you figure out what the problems are so you can address them. The next slide is kind of one of those, I found it extremely interesting. I'm not sure if you guys remember in 1974, when Philippe walked across the Twin Towers, right? That's an amazing feat. No harness. It was just him, the cable, his feet, and the pole, right? So what is required for that individual to go from one tower to the next? They need core control. They need those gyroscopes to be working properly. They need good feedback coming in from the feet. The feet are the only thing that are making contact with that cable. So it is so important to make sure that the brain is getting that feedback. If that feedback is not there, he's going to fall. He requires strength to maintain that posture, right? He requires core control. We talk about core control, and a lot of people say, what in the world is core control? Well, we're talking about strength in the hip, the pelvis, the lower back, because it's not only about the legs. In order to address the frequency and minimize the frequency of the falls, you have to address from the ankles up, and really from ankles up to about the ears, because you need the inner ears, the little gyroscopes, you need the lower back working fine, and the core strength. As Dr. Ibsen earlier was talking about stenosis. So if your favorite mode of transportation is walking forward, what happens is you're shifting your body weight off center. The center of gravity has been disturbed. Right off the bat, your gait pattern or your walking pattern is abnormal. So you increase your likelihood of falling, right? So we have to figure out the problem, right? So you need to have your factors addressed or figure out. It could be a combination of physical therapy, of physicians, some healthcare provider to assess or address what the needs are, whether it's visual disturbances or needing updated glasses or maybe accommodating for the bifocals or trifocals that we may wear. So pain management is another factor that in the research was discovered to be one of the high risk factors, and it makes complete sense. If it hurts to take that step, you're going to rush. And if you're rushing to go from point A to point B, you're going to make that unsafe decision to either try to sit too soon when the surface is not ready, or you're going to miss the chair completely, or you're just going to hurry so much that you're in that tripping on your own feet. So it is so important to have pain management addressed. Of course, medications may need to be addressed from the standpoint of if there are medications that are making you too groggy, sometimes go into a different set of medications that may be more appropriate for you to still control your symptoms but minimize some of the side effects. The physician can help address blood tests, for example, to see what vitamin deficiencies that you may have, as well as what exactly is VOR, the vestibular ocular reflex, and that's where James comes into play. Having tests performed to assess whether or not the reflex between the neck and the eyes is working properly and that gyroscope is working properly. What occurs, and I was going to talk about this in a little bit, well, the doctor's already mentioned about physical therapy, but anyway, so what happens is if the every time you turn to the right, the little gyroscope in the inner ear has little canals with fluid. So when you turn to the right, there's fluid that flows in that direction that tells the brain which way you're turning. If that fluid is not working, is not moving properly, the brain is not getting triggered that your inner ear is being stimulated to the right. The neck muscles are telling the brain, yes, we are turning. Visually, your body knows or your brain knows that it's turning, but one of the key components, that little gyroscope, is telling the brain we're not moving. If for whatever reason, maybe blocked, maybe damaged, maybe injured, but if that gyroscope is not moving, you're going to lose a key part of the equation to keep you upright and to keep you from falling. So benefits of therapy, right? So of course the strengthening exercises, right? Cardiovascular endurance, that's also really, really important. We talked about strength, but it makes no difference if you can squat 1,000 pounds, but if you cannot walk 15 feet from point A to point B because you're in pain or you don't have the strength or you don't have the endurance, that also needs to be addressed. So that's something that a healthcare provider can help you better understand and better address those needs to promote a healthier environment. Flexibility and range of motion exercises. If your joints are stiff, they're not going to move as well. You're going to end up potentially falling. Transfer training. Sometimes we need those little reminders as to how to get up and down safely without missing that chair, how to maneuver around walkers, as somebody pointed out earlier this afternoon, who had a misfortune. So you have to be aware of those little things to make you safe and keep you upright. Patient and family education is also really, really important. If a patient has an inner ear problem, family cannot perceive that. The patient knows that they get dizzy, they have vertigo, they get lightheaded, maybe they have passing out events, and there are certain things that are, treated by therapy, and other things that may be cardiovascular that, if as a therapist I see it, I need to refer back to the physician for further testing or the primary care doctor. But there are a multitude of factors that can make you lightheaded and dizzy and feel unsteady. And it's really, real important that you get those addressed. Proprioceptive training, we talked about those receptors. So can those receptors be improved once they're damaged, or as we age, they wear out? Of course. If I can make a muscle get stronger, and if you can contract the muscle, you can get it stronger. If you can contract the muscle and get it stronger, you can improve the endurance. If you can improve the endurance, you can start working on that awareness, a self-awareness of your posture and position in space, so that we can minimize this position, get you a little more upright, so we can improve that feedback coming from the feet, so you don't have to look at your foot every time that you're taking a step. And it is so important, once again, to maintain proper posture. So benefits of therapy, right? You have to correct and improve those gait abnormalities, right? If we don't take care of the problem, if I take a hammer and I keep banging my hand, I can do, pain medications, I can do surgery, I can do physical therapy, or I can just quit hitting myself with the hammer, right? So if we can figure out what that hammer is, let's try to remove that hammer if possible. Make it simple. We need to keep you healthy. We need to keep you active. There we go. So I kind of talked a little bit about the vestibular ocular reflex earlier. So that little aspect, as I said, you may or may not know that you have an issue with it sometimes until it's too late. But if you see problems such as, hey, I turn fast to the right and I get dizzy, or I look up and all of a sudden my legs start to wobble, you need to have those things addressed before you fall, right? If the brakes are faulty in your car and you have problems stopping, you don't fix those brakes after you've crashed it, right? You try to address the brakes beforehand. The VOR, that little reflex, that little connectivity between the inner ear and the brain, can definitely be affected by medications. It can be affected by alcohol. It can be affected by trauma. It can be a congenital problem. And it can also be affected by lack of stimulation. If you spend a lot of time sitting on that couch, you're not going to get that feedback training that you need, and you're going to lose some of those receptors. All right, so we talked about the dizziness. So vestibular rehabilitation therapy, it goes by, we like to use a lot of $10 words in therapy or in medicine. Makes it sound a lot smarter, but it really comes down to figure out what the hammer is and get rid of the hammer, right? If we can do it. So what I would encourage you or encourage people is have the follow-up with your physicians if you're having problems. If the issue is addressing pain level in the knee, have that looked at. If the issue is blood pressure problems, have that looked at. Don't wait until it's too late. If the issue is dizziness every time you turn or every time you look up or down, there are a lot of key components that as physical therapists we can treat very easily. Sorry about that, guys. I went one too far. Got too anxious. All right, Bppv. That's probably like a $1,000 award right there, right? So what in the world does that fancy term mean, right? That's a condition where those little canals, there are 3 canals in the inner ear, matching sets. There's a canal that is relatively level to the floor. There are canals to the front, canals to the back, inside that little gyroscope. Every time I turn my head one way or the other, fluid flows, and as the fluid is flowing, it pushes the little hairs down, tells the brain, hey, I'm turning down, or I'm looking up, or I'm going to the right, I'm going to the left. The brain needs that feedback to preemptively activate muscles to keep you upright. If I'm going to turn to the left, I need my left foot to go with it, right? If I turn to the left and my left foot is not getting that information because the brain never got that information, I'm probably going to stumble and fall, right? Or if every time I turn my head to the left, I get overbalanced and I have to stagger and hold on to stuff, there's something going on in there that potentially could be addressed with physical therapy or medications. So it's important to have those things tested. Also with that Bppv, it's one of the most common reasons of dizziness in patients or individuals 60 years and older. It is also a condition that can be easily treated. There is about a 75 to 78% success rate within 1 to 3 visits. So I'm talking about those in the inner ear. If little crystals break free and clog up that little canal, right, the canals that I was describing earlier, and one of the canals is clogged with those little crystals, so it's no longer flowing fluid. Every time I turn my head to the right, and my brain should be receiving the information that there's something moving, but it's not receiving the information because it's clogged up, then I'm going to lose my balance because I will get dizzy and unsteady. And that dizziness or that can be so severe that you can become nauseated and actually vomit and get extremely ill. The thing with that to keep in mind, it could be easily treated if the canals are blocked. 1 to 3 visits of physical therapy, specific maneuvers. We have to figure out which canal is blocked. We have to treat it with a couple of 2, 3 times, and then you're good to go. So it's something that, being so simple, I hate for a lot of patients to experience vertigo where it could be easily treated. All right, that's kind of lit. This one's kind of hard to see, but it's a little GIF, you know, the person laid down, the canals are being, well, that's the problem with being short, guys, right here. There we go. So what happens, those little crystals move out of their specific location. They should be kind of hanging up on the wall. They break free. They start floating through. They clog the canal. Every time you move, those are clogging the fluid and creates that vertigo. And of course, we get unsteady and we can become easily violently ill. So there are maneuvers that as physical therapists we can employ to flush those canals to alleviate the symptoms and fix the problem. Like I mentioned earlier, about 70–80% success rate in 1 to 3 sessions. One of the things that I find it fascinating is nystagmus. I don't know if you guys can see. It's a small little GIF. It's not even moving, but it should be moving. Go figure. There we go. Can you guys see that? Kind of played it for a second. I apologize. I was supposed to have it in a continuous loop here. But anyway, nystagmus refers to a little abnormal eye movement. That's something that your family members may or may not perceive unless they're looking for something. That's something that the patient may or may not necessarily know that their eyes are bouncing. But that is something that is occurring because of the blockage in the inner ear. If your eyes are shifting so hard that they cannot focus on the object, you're going to more than likely lose your balance. And if the eyes are bouncing back and forth, your brain doesn't know why they're moving. It just knows that they're moving, but it's receiving a lot of mixed information. The neck is not moving, the patient's sitting still, right? But the eyes are still bouncing. So the brain is perceiving that movement when there is no movement. And that's what makes people dizzy or nauseated when they're laying in bed. You roll to your left or roll to your right, and all of a sudden the world starts to swirl, right? So that is something, once again, that James can address with some of his computerized equipment to figure out if there is an issue within the inner ear, so that he can tell us or tell physical therapists, hey, this is going on, you need to treat it. And then that's why it's so important to address this as a team. It's, we all have to be on the same page, the family, the patient, as well as the healthcare providers. So, basic instructions for the house, right? Things that the patient can do. Obviously installing grab bars and railings, non-skid surfaces on the steps. Those are areas where you're coming into the house with your feet are wet, slip on the step, and there you fall. Using adaptive equipment. I have a lot of patients who don't necessarily want to use their canes because it doesn't fit their style, or maybe they're not old enough to use that cane or that walker. But there are times when you need that assistive device to keep you upright. I'd rather have my cane than have a broken hip. It's just a little easier to prevent. Proper lighting. Earlier I mentioned that 10% of the information that affects your balance is coming through visual input. If you cannot see, you're losing 10% of the information. If you have diabetes, you're losing some of that information coming in from the legs. So you're kind of putting yourself at a disadvantage. So it's so important to make sure that we're using night lights, we're turning the lights on when we get up in the middle of the night. And concerning night lights, this is an important factor to keep in mind. So you have a bunch of night lights in the house, so power goes out. What happens to the night lights? They went out, right? I'm going to make a little plug here for Walmart, and I'm sure Lowe's has the same thing, right? Walmart sells these little battery, it has a little charging night light. And what happens, it has a little built-in battery. It's constantly plugged in, so it's charging. Power goes out, light comes on, right? It's amazing. We have light when the power's out. Now I can see where I'm going, right? Another factor to keep in mind is flashlight. Don't keep the flashlight across the room. Keep it in, in your nightstand. Or having multiple flashlights, because if I happen to be in the bathroom when the power goes out and my flashlight is in the bedroom, I'm either going to have to holler for somebody or I'm going to have to stagger there. So I'm increasing my own risk of misfortune. So keep that in mind. Night lights with batteries so that they can come on. At my house, I have, kind of geeky about certain things, but so at my house, I have these little flashlights, right? They're constantly charging. So I just get it out of the outlet. I have them scattered throughout the house. I can use it as a flashlight, or I can have it come on as a night light. So when my kids were little, that was perfect for them. Now they hide them and I can never find them. But since you guys don't have kids, little kids anyhow. But anyway, that's another problem for me, right? So anyway, so we talked about accessibility of flashlights and the visual input. Getting rid of the clutter is important, right? So if we have a rug here and it's bunched up and I trip on it and I fall, it was something that I could have prevented by just putting it out of the way or removing it. If I have a knee replacement and I'm going to temporarily be using a walker for several weeks, let's just put those throw rugs away. Minimize the chance of you falling. Make sure that you're wearing your shoes or your non-skid socks, not just regular socks. Regular socks will slip on tile flooring, linoleum, as well as hardwood flooring. Watching out for pets. How many times have we taken that trip because the cat got in the way or the dog got in the way? So it is really, really important to make sure that we're aware of our surroundings, right? And then if you start complicating things, lights go out, the flashlights that are across the room, now we have a small pet that's tripping us. So keep that in mind. So what can we do, right? So we have to, as patients, because I've been a patient, you guys maybe have been patients, we have to comply. If you're given a blood pressure medication and it just sits on the cabinet, it could be the best thing ever. But if you didn't use it, didn't take it, it's not helping you. Same thing with, with your exercises. If you're given exercises by your therapist and you're not doing them, you're not helping yourself. So it's important to make sure that you're compliant and actually taking part in your recovery and in preventing the problems. Keep moving, keep exercising. It is encouraged 2 to 3 times weekly to help lubricate your joints, maintain your balance, and maintain your strength and your cardiovascular endurance. Make sure that you're joining exercise classes for patients who have arthritis, and how many of us have arthritis in the room, right? A couple of us, right? So it's important to make sure that if we can instill some sort of program in the water. The advantage of the water is whenever you're in the water about chest deep, you have about 60 to 80% less loading on our joints. It's going to be better for the ankles, better for the knees, better for the hips and the back. Plus, it minimizes when you're in the water, if I take a stumble, I'm not going to fall hard, right? So it's the perfect opportunity to work on exercises that might be too challenging on land to do them in the pool. I said whether you're doing them in a supervised program with a therapist or at the Y, or you're doing them in some sort of wellness program. But stay active. I appreciate everyone's time for being here. Thank you so much. And it was great to see a bunch of faces I haven't seen in a while. Thank you.
Again, my name is James Adams. I'm a physician assistant here at Ortho Four States, and I work in the fall prevention clinic as well as bone health clinic. My assistant, Wendy, is probably the first person you're going to see and talk to if you ever get a referral to either one of those clinics. And if you come to fall clinic, this is the first thing she's going to do on you, which is called a balance plate test. This test is 4 stages or 4 steps to check your balance on solid surfaces with your eyes open and closed, as well as a foam surface with your eyes open and closed. It takes about 2 minutes to do the entire test. It is one of the indicators to see if you need to go on and have a video nystagmus graph, or a VNG as you've heard it called. Not everybody needs a VNG. A lot of times we can address the problem that you're having by just doing this simple test and have you follow up in physical therapy, where they do a wonderful job, by the way. So I'll demonstrate how this test goes. She's going to make you get barefooted. And this is the easy part. Standing on the solid surface is the easy part. We try to keep something in front of you just in case you do lose your balance, you have something that you can grab and hang on to. Put your arms down by your side.
Just look straight ahead. We do 4 10-second tests, 2 with your eyes open, 2 with your eyes closed, 2 on the solid surface and 2 on the foam surface. Okay, so the first one's going to be eyes open. Now it'll actually start.
Did it start?
You can't hear anything. And then this one's going to be for your eyes closed.
Tell me when.
Start. Okay, now I'm going to have you step off. We're going to do the foam surface.
No.
I usually stand here and put one hand behind the patient, one hand in front of the patient so that they don't fall.
You ever stood on a mattress and changed a light bulb? This is it.
Okay, so this one's going to be eyes open.
God, this is poor form. I'm going to flunk my own test.
About 5 seconds. And now this one's going to be the eyes closed. This is the tricky one.
Tell me when.
Go ahead.
Hmm.
It's hard, isn't it?
Jeez.
Okay, now you can step off.
Man, that thing's harder to ride than a Brahmer bull. So maybe I need to go to my own clinic.
It's not going to show your results because I put tests in there.
All right. After you have your test done, we print this out on a bar graph so you can kind of get an idea, we can get an idea of where you may have some balance deficit or issues. All green means this person did really well. If there's any kind of deficits, you'll see the red. If they're kind of teetering on whether they're good or bad, that line will be yellow. But that tells us a lot. You know, on this patient, they're not any good with their eyes closed. So we make an appointment with them for the fall prevention clinic, talk to them about, like the other speakers said, medicines, problems with their backs, problems with their knees or hips, vision, all kinds of different things, hearing. And then we kind of get a better idea of whether or not we need to do the video nystagmus graft as well. We also have them fill out a questionnaire that, according to the answers of their question, really can get us more focused on those who need this test and those who don't.